Morning, everyone. Good morning. Good morning. My name is Alexandra, and we are here for another session for NCLEX review. We are going to be finishing up adult renal. So, if you need the recording from last week, make sure you use the document I always send that has the Zoom link on it, and you will see under Module 6 the recording for renal part 1. After today's session, I will send you the recording as well. So this would be renal part 2. So we last left off on hemodialysis. So hemodialysis basically is you are using a machine to do the work of the kidneys. So when somebody needs hemodialysis, they have renal failure or they have chronic kidney disease stage 5, which is also called end-stage renal disease. The functions of hemodialysis is to clean the blood of accumulated waste and to remove the byproducts of protein metabolism. So remember, when somebody has kidney failure, they cannot break down protein the way they should. And so that's why somebody with kidney disease is going to be on a low protein diet. Another function of hemodialysis is to remove excess bodily fluids. So somebody with kidney disease, their kidneys are not working properly. Their kidneys are not filtering out the wastes, and their kidneys are not removing excess fluid from the body. So the fluid is going to stay inside the body, and that is going to increase the blood pressure, which will also put more burden on the heart and the kidneys. Okay, so now we're going to talk about interventions. So somebody who is on dialysis or receiving dialysis, you want to monitor their vital signs. You want to monitor their renal labs like BU1 and creatinine. Always assess for fluid overload. So check their blood pressure, check for edema, check for any shortness of breath. You want to weigh the client before and after dialysis to determine the fluid loss. So we weigh them before they go to dialysis and after, so we can compare and say that they dialyzed 3 liters of fluid. Basically, they lost 3 liters of fluid through dialysis, right? And it's also very important that any antihypertensive medications, you don't want to give them blood pressure medication before they go to dialysis, because after going to dialysis, their blood pressure might drop. Okay, so just always keep in mind when you're sending your patient to dialysis, their blood pressure is going to drop because we're removing fluid from their body. We're removing fluid volume, the heart will work less, the blood pressure will drop. So we don't really give blood pressure medications before a patient goes to dialysis. If your patient has high blood pressure and they have dialysis scheduled that day, call the healthcare provider so they can guide you on what to do next. Next, we're going to talk about access for hemodialysis. So I want to bring your attention here to the PowerPoint slide. So hemodialysis access, okay? So there's 2 main types of dialysis. Hemodialysis, where we're using the blood, and peritoneal dialysis, where we're using the abdomen. So for hemodialysis, you have 3 major types of access: a central line, AV fistula, or AV graft. A central line is basically an IV. An AV fistula is surgical, where the surgeon sews together an artery and a vein. And we're going to talk about that. And an AV graft is when the surgeon uses a synthetic device to connect an artery and a vein. So this is an example of an AV fistula. Okay, so a fistula means abnormal connection. It's something that it's not natural. So arterial venous fistula or AV fistula, this is when a vascular surgeon connects surgically an artery and a vein and sews them together so that the high pressure of the blood flowing through the artery can make the vein become very large. And that large fistula is what they will put the needle through when they are doing dialysis. Because in order to do dialysis, a needle has to enter the blood vessel, and the needle needs to be able to take the blood out, and then another needle will be used to put the blood back in. So the blood comes out of the body and goes through the dialysis machine, and the dialysis machine will cleanse the blood, remove the wastes, and remove the excess fluids, and then the clean blood will be put back into the patient. Okay. Then this is an AV graft. So you see the difference? AV fistula is surgically, they sew together an artery and a vein, and the high pressures will make the vein engorge and be able to withstand the pressures of the dialysis machine. This is an AV graft. You see, they still surgically connected a vein to an artery, but they used a synthetic device, which they call a synthetic graft. Okay? And the high pressures of the blood from the artery will go to the vein. Okay? And they will connect two dialysis needles to be able to perform the dialysis. So let's go back. So dialysis access, let's talk about central lines. So central lines are basically an IV, and you can only use, if a central line is placed for dialysis, you can only use that central line for dialysis. So we can't use that central line to give fluids and IV antibiotics and medications and electrolyte replacement. The only way we can use a central line for dialysis for something else is if the doctor gives us an order. Okay, so remember that for your nursing career. If the patient has a central line that was placed there for dialysis, you can only use it for dialysis. I even had a patient who, well, I was helping, they were coding, so we're doing CPR on them. And you know, a patient, you're doing CPR on them, you need an IV. We still, in the middle of doing CPR, we had to ask the doctor if we can use that central line because it was there for dialysis. We had to ask if we can use it for the code. And he said yes. He was in the room. So a central line for dialysis is temporary. So this is not something where for the rest of their life they can have this central line in place and we use it for dialysis. Why? Because central lines increase the risk for infection, bloodstream infection. A central line is a longer IV that goes towards the center of the circulatory system, towards the heart. And so these are longer and larger, and there's an increased risk for bacteria to get inside and spread. So a central line used for hemodialysis is just used temporarily until a more permanent solution can be placed, like an AV fistula or AV graft. And then even once you place, or even once you have the AV fistula or graft in place, an AV fistula needs 3 months to mature, right? So if they put a central line, let's say in the patient's chest, because central lines, you can do subclavian or you can do femoral, okay? Central lines for dialysis, subclavian or femoral. And I'm sure there's other options, but those are two common places. So the subclavian central line would be like right on the front of their chest, and femoral would be in their groin. You can imagine, because central lines increase the risk for bloodstream infection, that they don't prefer the femoral because the groin tends to be very sweaty and that's where pee is and all of that. And also the groin is where we bend the leg, and that would kink the catheter. So they prefer subclavian. It's in the chest doesn't bend, and it's a lot easier to keep a subclavian central line clean. But anyways, they will put a central line in for dialysis until either one of these can be performed. AV fistula is definitely the ideal dialysis access, 100%, because as long as it keeps working, you can use it forever. The problem is with the AV fistula, it needs 3 months to mature. So they will probably place the central line in first so that they can start doing dialysis. Because if the patient needs a central line for dialysis, they are going to die if we don't do dialysis very soon. So emergency purposes, somebody needs dialysis and has no access, they will place a central line. Then between the nephrologist and vascular surgeon, they will decide what permanent form of dialysis access the patient needs. And it's probably going to be an AV fistula. So in the 3 months we're waiting for the fistula to mature, we will use the central line. Okay. So hemodialysis AV fistula. So this is this picture. We talked about it. The high pressure through the artery causes the vein to grow larger and be able to handle the high pressures of the dialysis machine. An AV fistula is permanent and can be used forever. The number one goal after creation of an AV fistula is to monitor for patency. So make sure you write that down. The number one goal, we have to make sure that it is open. And because we need this for the patient so they can get dialysis. But if a blood clot gets stuck in there and it's not working, circulation is not moving through there, then the whole reason we created it, it's gone. It's ineffective for what we need it for to keep the patient alive. So we have to monitor for patency. So this introduces two very important terms that you need to know for your nursing career: bruit and thrill. Okay, I heard somebody pronounce it bruit or bruit, but I say bruit. Okay, and you have to memorize these for NCLEX, and you have to know them for your nursing career. So what's tricky is, how do you assess bruit and how do you assess thrill? Well, I just want you to remember ABPT. And also it's alphabetical order, ABPT. You auscultate the bruit and you palpate the thrill. So NCLEX loves to try to trick you on that. Like, well, how do you assess bruit? You use your stethoscope. You put your stethoscope over the fistula and you auscultate bruit. You're going to hear a loud whoosh, 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 a very turbulent blood flow. And how do you assess thrill? You're going to wash your hands and dry them and put 2 fingers over the AV fistula. You can put gloves on too if you want. But, because this is under the patient's skin, right? But still, you put your fingers over the AV fistula and you're going to feel or palpate the thrill. You're going to feel that quick, turbulent blood flow. So you auscultate the bruit with your stethoscope and you're going to hear a turbulent blood flow, like a whooshing, and you palpate the thrill, okay? If there is no thrill or no bruit, that could indicate a possible clot. You need to notify the healthcare provider immediately. So this is why in the beginning of your shift, you should, during report, you need to know, did the previous nurse auscultate bruit and palpate thrill? Because if they were able to find those there, you should be able to as well. And if you're not able to auscultate bruit or you're not able to palpate thrill, you have to notify the healthcare provider immediately. So this is something you want to find out and report. if they were able to auscultate, breathe, and palpate through, it's something you want to do the first thing at the beginning of your shift as part of your initial assessment of the patient, and something you want to do maybe halfway through and then towards the end of your shift, or more often as needed, right? But this is something you want to keep track of as a nurse. So that is why getting a good report is so important. You want to know if the patient has an AV fistula so that you can auscultate for bruit and palpate through and keep your eye on it. And also you need to know where the AV fistula is, because wherever they have an AV fistula or graft, you cannot check blood pressure on that extremity. You cannot draw labs like venipuncture. You cannot do that on that extremity. You cannot put an IV in that extremity. So getting a good report is so good, but just remember that all of us nurses, we are humans. Maybe the nurse before you forgot to tell you they have an AV fistula. However, that's why you always want to get to work early so that you can look up information on your patient, right? And you can look and see their history. Look and see what the previous shifts have charted, so that if somebody has noted an AV fistula, you can ask the nurse during report, oh, do they have an AV fistula? And the nurse might say, oh, yes, they do, in the right lower arm. I'm so sorry, I forgot I had a crazy night last night. It's all right, we're here as a team. Thank you for letting me know. And then when you go in the room, assess it, right? So when you go in your room for your first assessment, you want to check their vital signs. Make sure if they have an order for heart monitor, they're on it. What's their current rhythm? If they're diabetic, when was their last blood sugar? And when do you need to check it? Does it look like you need to check it now? And if they're on dialysis, where is their access? Is it a central line? Let me assess it for signs of infection. If it's an AV fistula, let me assess for bruit and thrill. Then you do your head to toe, front and back. If your patient is a fall risk, make sure they have the call line. Make sure the bed is locked. If your hospital uses bed alarm, make sure it's on. You leave them with the call line and say, thank you. That was just my first assessment of you. I will be back shortly with your medication. You see, that's how the first assessment of your patient should kind of look like. Okay? So remember, the AV fistula, it's very, very excellent. It's a very excellent choice for dialysis access because it's permanent. You can use it forever as long as it's still working. But it just needs about 2 to 4 months to mature. And one of the quickest ways we can do that is to tell the patient to squeeze a tennis ball. Okay. Next up, this is an AV graft. So here they used a synthetic graft to connect the blood flow, the high pressure blood flow from the artery, going to the vein to swell and engorge it. The only issue here is the risk for infection is high, and I think I have it here. Hold on one second. So this is this one, the internal AV graft, okay? So some issues that you might face here is clotting, bleeding, and dislodgement, where the graft might move out of place, okay? Anyways, long story short, we've gone over what's important here. So make sure, let me tell you the page number. Towards the bottom of page 205 in your study guide, make sure you read your interventions for how you care for a patient that does receive dialysis. So you're not going to really give the patient dialysis unless you are a dialysis nurse. So most of what you're learning, because remember, I'm preparing you for the NCLEX, and NCLEX just wants you to be trained to be an entry-level nurse. So an entry-level nurse is not really going to be a dialysis nurse, right? That will take training and specialization. So we're preparing you to be an entry-level nurse. And so as an entry-level nurse, you have to understand why a patient is on dialysis, how they do it, what type of dialysis access the patient has, and how do you care for the patient before and after dialysis, right? While the patient is receiving dialysis, that is for the dialysis nurse. So you know that before dialysis, you want to get vital signs and you want to get a weight. Throughout your care of the patient, monitor the renal labs, BUN creatinine, and the electrolyte potassium. You want to monitor your patient's potassium level because remember, patients who are on dialysis, they have end-stage renal disease and they are at high risk for high potassium levels. So these are things you want to check often. So first thing you start taking care of the patient, what is their BUN, what is their creatinine, what is their potassium? You can also check their magnesium and their phosphorus and their calcium. You want to make sure you remember if they're going to dialysis, let's say it's 9 a.m. and they're going to dialysis at noon, giving them their blood pressure medication before dialysis, it can cause their blood pressure to drop. So if their blood pressure is normal, you can reschedule their blood pressure medications for when they get back from dialysis, right? But keep in mind, if before the patient goes to dialysis, the blood pressure is high, call the healthcare provider and ask for guidance on how to move forward. Because you don't want the high blood pressure sitting there and the patient, God forbid, have a stroke before dialysis. So that's why, let's say it's 9 a.m. and the patient is going for dialysis at noon. You check the blood pressure and it's 201/85. So that's very high. And they do have blood pressure medication. Just contact the healthcare provider and say, hey, I just want you to know that the patient's blood pressure is this. Can I give the blood pressure medication? Mind you, you don't want to wait too long, right? You don't want to wait too long. So if it's been 5 or 10 minutes and you haven't gotten a call back, escalate to your charge nurse or your unit manager, okay? Because you don't want that high blood pressure sitting there too long because you're responsible for it. Okay? And when in doubt, they can always do the dialysis at a later time that day. So those are some things to think about, but it's always best to get guidance from the healthcare provider regarding that. All right, so that is hemodialysis. So let's take a short 5-minute break. And when we come back, we are going to talk about peritoneal dialysis, which is dialysis through a catheter in the abdomen. And then we're going to do questions on dialysis. Thank you. So peritoneal dialysis is using a catheter that was placed through the abdomen to perform dialysis. Many people like this because they can do dialysis from home. And so what I want you to know is your number one priority for somebody who's receiving peritoneal dialysis is they are at increased risk for an infection called peritonitis. So please make sure you memorize that. Peritonitis is a severe infection located in the abdominal cavity. And so I want you to know the signs and symptoms of peritonitis. So that is on page 208 at the top. Fever, cloudy outflow. So what is outflow? Peritoneal dialysis, basically, you can see the catheter that goes through the peritoneal cavity, and that catheter will stay there unless it stops working or the patient gets a really bad infection because of it. And so basically, they have the diastole that goes inside the peritoneal cavity, and it's going to sit there for a certain amount of hours. It might be overnight, it might be 8 hours. And the time that it sits in the peritoneal cavity, that's called the dwell time. And the healthcare provider will make that order for how long. And so it will sit there, and while it's in the abdomen, as you can see here, excess fluid and wastes are going to leave the blood and enter into the fluid that's sitting in the abdomen. And at the appropriate time, whatever the healthcare provider has ordered, then we're going to allow the fluid to drain out into a drainage bag. So, a couple of important things. When we're connecting this solution, the dialysate, we need to use sterile technique, because if any bacteria, because you know how you spike the IV bag, we spike this bag. So if you cough on the spike or touch the spike with your bare hands, or your hands aren't washed correctly, bacteria is going to go inside the fluid, and the fluid's going to go inside the abdomen and cause peritonitis, because your abdomen has a very rich blood flow. Why? Because your GI tract, your intestines, everything, that's how nutrients get into your bloodstream, right? From what you eat. So, because the abdomen has a very rich blood flow, there is a high risk that if bacteria were to enter the abdominal cavity, that same bacteria could easily jump out of the fluid and into the bloodstream, and then to the heart, and then to wherever it wants to cause a really bad infection. Okay, so we use sterile technique when we are spiking this bag for the dialysate. Okay, also we use sterile technique when we're cleaning the peritoneal catheter. Another important principle is the drainage bag should always be below the abdomen. So you never want like the drainage bag is on the bed with the patient. No, it needs to be below the level of the waist, so that we don't want this fluid to go back in. Okay? And this fluid that's draining into the drainage bag, it's called outflow or effluent. Okay? Also, when it's time to drain the fluid out, you want to keep the patient semi-Fowler's. Okay. So, peritoneal dialysis, make sure you know the major principles we talked about. The number one priority is peritonitis. So, on page 208, make sure you know your symptoms: fever, the outflow or the fluid that's going out. If it looks cloudy, that's a sign of infection. Okay. Rebound abdominal tenderness, so the abdomen is tender, they have abdominal pain, nausea, vomiting. Those are signs of peritonitis. So what we would do is we would obtain a sample of the outflow for culture, and after we send that culture, we give antibiotics as ordered. Okay. We don't want the dressing that is around the peritoneal catheter to become wet or dirty. If it is, we're going to use sterile technique to change that dressing. So some troubleshooting. So as you can imagine, anything in life, there's a potential for some kind of complication. So as a nurse, just make sure you know that what you put in for peritoneal dialysis, you should expect to come out, plus whatever excess fluids are drained from the patient's body. So this is just an example, but if 2 liters comes in and 3 liters comes out, you're going to say, so I put 2 liters in and I got 3 out. So 2 of that is from the dialysate, and the extra 1 liter is the actual patient's excess bodily fluids that were removed, right? But if you put 2 in and only 1 comes out, that's a problem, because that means that the catheter, something might be wrong with the catheter. So how do we troubleshoot? So insufficient outflow. So if not a lot of fluid is coming out, the major cause is a full colon. So a major cause, because you can see the colon is right here, and your intestines are here. So if the patient is constipated, that is a major cause of why not enough fluid is coming out. So we want to encourage a high fiber diet. We can give stool softeners as ordered, and that can help evacuate the bowels and hopefully allow some more. Because if this is full of poop and it's pushing the intestines forward, and the intestines are smushing this catheter. This has little holes in it here to let the fluid out. Not a lot is going to get out. So if the patient evacuates their bowels and they have a bowel movement, this should push back and allow the intestines to come off of the catheter, and the patient should have a good restoration in normal outflow. Another reason why there could be not enough outflow is maybe the catheter moved. So if you suspect that, if the patient's not constipated or they just recently pooped on your shift, and you just feel that something's not right, ask the healthcare provider for guidance, and they might order an x-ray, and the x-ray can tell the healthcare provider where the catheter is to make sure that it's in the right place, because it could have moved and got stuck somewhere. Also, check for any kinks in the outside tubing, right? So if this is twisted right here on the edge of the bed, that could be a reason why not a lot is coming out, right? Okay. Some other issues, if this outflow is cloudy, that indicates peritonitis. If the outflow is red, that could indicate bleeding or vascular complications. Contact the healthcare provider. If this outflow is brown, that could indicate bowel perforation, like the catheter accidentally punctured the intestine. And that's poop in there, so that's not good. That's not what we want. And that means poop is just freely traveling around the abdominal cavity, and that's definitely going to cause peritonitis and sepsis and death. So we would definitely want to alert the healthcare provider. Okay, so those are the basic principles of peritoneal dialysis. Okay, so give me a few moments and we're going to do some questions on dialysis. All right, everyone, let's do some questions. The client in acute renal failure has an external cannula inserted in the forearm for hemodialysis. Which of the following nursing measures is appropriate for the care of the client? What would you choose if this was the NCLEX? Question 47. Please put your answers in the chat. The client in acute renal failure has an external cannula inserted in the forearm for hemodialysis. Which of the following nursing measures is appropriate for the care of this client? Very good. The correct answer for 47 is choice one. So just remember, any type of dialysis access, it doesn't matter which type. If a patient has a dialysis access in an extremity, we cannot use that extremity for blood pressure, to draw labs. Also, you see how they tried to trick you with choice three? You see how they tried to say percuss brewy, and that's when you're going to remember ABPT. It's in alphabetical order. ABPT. You auscultate brewy and you palpate the thrill. Okay, you don't percuss brewy, you auscultate brewy. And we don't use heparin into the cannula each shift. The dialysis nurse will take care of the actual dialysis access. We're there to monitor it, and if it's a central line, with the orders, we can change the central line dressing each week. However, we don't inject heparin into the cannula each shift and then draw blood from the cannula. Nope, nope, we don't do that. Okay. We would draw blood from the other arm that has no dialysis access. 48, so this is a learning question. We didn't talk about it yet, but we'll use this question to learn from it. During the first hemodialysis treatment, the client develops a headache, confusion, and nausea. The nurse should assess the client further for what is the correct answer? All right, everyone. The correct answer for 48 is number one, disequilibrium syndrome. So I wanted to put this question up on purpose because, first of all, because a lot of people chose option four, right? But there's one word in the question that makes it impossible to be peritonitis. Because peritonitis is only an issue for somebody getting peritoneal dialysis. What type of dialysis is this patient getting? Read the question. What type of dialysis is this patient getting? They're getting hemodialysis. So, is hemodialysis the same thing as peritoneal dialysis? No. Hemodialysis is through the blood, right? Peritoneal dialysis is through the abdomen. So, how can a patient that's receiving hemodialysis be at risk for peritonitis? So, I put that question up on purpose. Even though we didn't talk about disequilibrium syndrome, I wanted to see if you're paying attention. Ladies and gentlemen, if you want to pass the NCLEX, the first step, besides learning the content, which is what you're doing here in my review, you have to learn how to read the question. Do not get a question wrong off of a simple word that you didn't pay attention to. If you want to pass the NCLEX the next time you go, you have to pay attention to the words in the question. Remember, hemodialysis is not the same as peritoneal dialysis. Acute kidney injury is not the same thing as chronic kidney disease. So any kind of question about dialysis or kidney disease, pay attention to, is it acute kidney problem or chronic? Pay attention, is it hemodialysis or peritoneal dialysis? So this you're going to use process of elimination. I did this question to show you that even if you don't know what one of them means, because we've never heard of disequilibrium syndrome before. I'm going to be honest with you, I never heard it before in nursing school. It's when I found this question bank, I saw this. And I said, you know what? This is a good question. I like it because you can still get it right if you use the process of elimination. Listen, read the question again. During the first hemodialysis treatment, the client develops a headache, confusion, and nausea. Headache, confusion, and nausea. Does that sound like myocardial infarction? No, because what's another word for myocardial infarction? A heart attack. Nothing in there says heart attack. Maybe nausea, right? Because sometimes women are nauseous when they're having a heart attack, but headache and confusion, if it said chest pain and shortness of breath and sweating and dizziness, then I could say maybe heart attack, right? But headache and confusion and nausea, that doesn't say heart attack. So process of elimination, because it's hemodialysis, you get rid of peritonitis. That doesn't make sense. Hemodialysis does not increase the risk for peritonitis. Okay? The symptoms do not align with the symptoms of heart attack. So you got rid of choice two. Air embolism. That's something where the patient all of a sudden would develop distress and maybe start coding, maybe have a flat line right away. Air embolism is like air got in the bloodstream. So that would be something very immediate where they would pass out. And when we were checking for breathing and a pulse, there would be no breathing or pulse, and we would do CPR. Okay. So through process of elimination, you got rid of these and you can feel confident saying, well, it must be this. So why do you think the first time they're getting this is their first time getting hemodialysis and they develop these symptoms? So common symptoms of disequilibrium syndrome include headache, nausea, vomiting, confusion, and even seizures. Disequilibrium syndrome typically occurs near the end or after the completion of hemodialysis. It is a result of rapid changes in fluid volume and composition of the blood. Okay, so what I want you to know is while the patient is getting dialysis, the dialysis nurse is monitoring the patient, monitoring the vital signs, monitoring the access site, and monitoring the machine, making sure that everything is working together the way that it should. If the patient becomes symptomatic while they're getting dialysis, one of the first things the dialysis nurse is going to do is slow the dialysis down. And then, if after slowing it down and maybe communicating with the healthcare provider, if the patient is still not doing well, they will then stop the dialysis treatment. So I just wanted you to know that. Okay, let's do question 49. Okay. 49. During dialysis, the client has disequilibrium syndrome. The nurse should first, what would you choose? Very good. The correct answer for 49 is 2. So remember, when things go wrong and the patient is symptomatic and there's a problem with the dialysis, one of the first things they would do is slow the rate of the dialysis. Okay? All right, question 51. So we're just doing questions that specifically I feel will prepare you for the NCLEX. So which of the following abnormal blood values would not be improved by dialysis treatment? So only one person got the question right. And again, you're not, I want you to think critically. Let's read the question again. Which of the following abnormal blood values would not be improved by dialysis? So elevated serum creatinine level, so that's a problem because of the kidney disease, but going to dialysis would fix that. It would remove the creatinine from the blood because somebody with kidney disease, somebody who needs dialysis has kidney disease or a kidney problem, and they're going to have elevated serum creatinine, and going to dialysis would reduce the creatinine level. Okay, somebody on dialysis has kidney disease, they're going to have high potassium. Going to dialysis would remove that excess. You see, dialysis is doing what the kidneys can't do at that point. So all of the problems a patient has because of dialysis, because of the kidney problem, going to dialysis is going to help fix it as long as it's related to the kidney. So elevated serum creatinine, hyperkalemia, and hypernatremia. Dialysis will fix all of that, but dialysis can't fix the hemoglobin problem. Okay? If a patient has a low hemoglobin, remember, that's because patients with kidney disease are anemic because their kidneys don't make enough erythropoietin. So we can give them the epoietin or darb epoietin, we can give them iron, we can give them blood transfusion. But dialysis is not going to help a patient with a low hemoglobin. Does that make sense? Okay, so let's do question 52. The nurse teaches the client how to recognize infection in the shunt by telling the client to assess the shunt each day for, what would you choose? We're on question 52. All right, so very good. The correct answer for 52 is 4. So there's one word that tells you why that's the answer. What is the one word in the question that tells you what to focus on? In the question, there's one word in the question: infection. The nurse teaches the client how to recognize infection in the shunt, not circulatory problems. You see, this is choice one is a circulatory problem. Choice two is a circulatory problem. Choice 3 is a circulatory problem, but it asks you, how did you teach the patient to prepare or to recognize the signs of infection? Okay? So does that make sense why choice 4 is the answer? So you have to, so far in the few questions that we've done, the issue here is you're missing one key word. So please, when you are doing questions and practicing, read the question carefully and pick out the key word. For each question, try to find like, what is the question asking me? For example, you read this question: the nurse teaches the client how to recognize infection in the shunt by telling the client to assess the shunt each day for. And so I would tell myself, okay, I taught the patient how to check for signs of infection. So what is a sign of infection? Absence of a bruit? No, that is a circulatory problem, not infection. Sluggish capillary refill? That's circulatory. Coolness? That's circulatory. But swelling, that aligns with infection. Okay? So really, if you want to pass the NCLEX, you have to learn how to read questions. Okay, let's do some more. Okay, question 79. A client with chronic renal failure is receiving hemodialysis 3 times a week. In order to protect the fistula, the nurse should, what would you choose? So you see, this question did a classic trick that I'm telling you, you are probably going to see this on the NCLEX. Remember, I told you to memorize. Let me make this bigger. I told you to memorize A, B, P, T, and it goes in ABC order, right? A, B, P, T. You auscultate, bruit, and you palpate, thrill, right? So you don't auscultate the thrill and palpate the bruit. They switched it in choice 3. So I specifically told you to memorize A, B, P, T. It's in ABC order. You auscultate the bruit, you palpate the thrill. So do you see how in choice 3 they switched it? That's what they do on NCLEX. And you're going to get it wrong if you don't memorize this trick. I want you to pass the NCLEX. So please memorize this. Okay? So you don't want to take the blood pressure in the arm with the fistula because you know that that could compromise the access site. You don't want to start a second IV in the arm with the fistula. So no punctures, no blood pressure on the same arm with dialysis access. But if you lose the thrill or the brew, you absolutely want to let the healthcare provider know right away. Okay. All right. Next question. We're going to do 80. This is a select all that apply. A client with chronic renal failure who receives hemodialysis 3 times a week. Remember, patients on hemodialysis, they usually get dialysis like Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Sometimes you're going to find patients that only do it twice a week, but that's not very common. So a client with chronic renal failure who receives hemodialysis 3 times a week is experiencing severe nausea. What should the nurse advise the client to do to manage the nausea? Select all that apply. So the correct answers for 80 are 2, 4, and 5. Okay. So drink fluids before eating solid foods. So basically, they say that if you drink in between the meals or that could make you more nauseous. Have limited amount of fluids only when thirsty, so that would help them to manage the nausea. Keeping all dialysis appointments, so that is so important. When a patient who needs dialysis misses appointments, what happens is all the wastes build up in their blood and they become very nauseous and very sick. So make sure the patient is able to keep their dialysis appointments. If they have issues with transportation or financial issues, or they are like an immigrant and are having trouble getting to dialysis because of their immigration status, please let case management know so we can help this patient so that they can get the transportation they need to get to dialysis. Because remember, if they keep missing dialysis, they will die. Okay, some of the sickest patients I've ever seen are dialysis patients that have come in because they've missed dialysis a couple times and they were really sick and very critical. Because remember, if somebody needs dialysis, their kidneys don't work, so their potassium is high. High potassium can stop the heart. Okay. Eat smaller, more frequent meals. Yes, because when you eat very big, large meals, that can make you more nauseous versus if you eat something small that might reduce the nausea. Okay. All right. Now we're going to do a couple questions on peritoneal dialysis. 81. The dialysis solution is warmed before use in peritoneal dialysis primarily to, what would you choose if this was the NCLEX? The correct answer for 81 is choice one. So I know we didn't review it, but again, I call this a learning question where we're going to learn something from the question. So the dialysis solution is warmed before use in the peritoneal dialysis, primarily to encourage the removal of serum urea. So remember, BUN, blood urea nitrogen, that is what's going to be high along with the creatinine level in somebody who's on dialysis. So helping the body to remove that urea from the blood, that is going to be more effective if the solution is warmed. Okay, remember we do not use a microwave to warm solution. Solution for peritoneal dialysis should be warmed to body temperature in a warmer or with a heating pad. Do not use a microwave. Diacylate is warmed to promote removal of serum urea, but also keep in mind that using cold fluid could increase discomfort. All right, question 82. Which of the following assessments would be most appropriate for the nurse to make while the dialysis solution is dwelling within the client's abdomen? Very good. The correct answer is choice two. So this is basically saying what is most important for you to assess while the patient has the fluid in their abdomen for peritoneal dialysis. So remember, the more full your abdomen is, the more likely it will affect your respiratory status. So just like a pregnant woman, she's usually short of breath, right? And that's because of increased intra-abdominal pressure. And just like somebody with liver disease and has ascites and their belly is full of fluid, it can affect their ability to breathe. So they literally have fluid in their abdomen, and what happens is it can press up on the diaphragm, and the diaphragm flattens, and that smushes the lungs. So that's why we want to observe respiratory status. Okay, question 83. During the client's dialysis, the nurse observes that the solution draining from the abdomen is consistently blood tinged. The client has a permanent peritoneal catheter in place. The nurse should interpret that the bleeding, what would you choose? The correct answer for 83 is 2. So remember, we learned in the study guide that when the outflow comes out red, it could indicate vascular complications like blood vessel damage. Okay, so let's see where it says that in the study guide. Okay, so on page 208 in the study guide, where it says bloody outflow after the first few exchanges indicates vascular complications. Okay, so that's blood vessel damage. Okay, so remember reading the study guide. Mostly every student that I've had who's passed the NCLEX after taking my review, they've always told me that the study guide really helped them. So I really want you to follow in their footsteps and pass. So please make sure you're reading the study guide, you're coming to class or watching the recordings, you're taking notes, and you review the recording and the notes, and then you do questions. Okay? So 84, during dialysis, the nurse observes that the flow of dialysate stops before all the solution has drained out. The nurse should. We're on question 84. The correct answer for 84 is choice 2. So when we're having issues with the dialysis catheter, we can ask the patient, we can turn the patient from side to side to hopefully, because sometimes the catheter is positional. And so moving the patient side to side can help the catheter find the fluid kind of and help remove it. Okay. All right. 85. A client is undergoing long-term peritoneal dialysis at home, is currently experiencing a reduced outflow from the dialysis catheter. To determine if the catheter is obstructed, the nurse should inquire whether the client has. Very good. The correct answer for 85 is 4. Remember, constipation is the most common cause of outflow obstruction or insufficient outflow from the peritoneal dialysis catheter. Flatulence is when they have gas, like they're farting. So constipation, remember the packed bowels, it can push against and make outflow insufficient. So asking the patient when's the last time they had a bowel movement would be a good starting place. Okay. All right. So let's go back to the study guide to just hit on some important things. Remember, the only way you can be well prepared is to make sure you're reading the whole chapter. So you have to go back and make sure you read the whole chapter on renal. Okay, so we're on page 208. So continuous renal replacement therapy. So this is something that would happen in the ICU, intensive care unit. This is a critically ill patient and they're getting dialysis like 24 hours around the clock. So this is a very ill patient and this is in the ICU. It's called continuous renal replacement therapy. Kidney transplant. Make sure you read this section. Kidney transplant, make sure you know that the patient must be on immunosuppressive medications for life. And make sure you know that when they are on immunosuppressants, they have to take it at the same time each day. In the hospital, if you're late giving immunosuppressants, you have to call the doctor and tell the doctor why you were late. So if a patient has received a kidney transplant, they are on immunosuppressants for the rest of their life and they have to take it on time at the same time each day. So, for other medications, you have an hour before and an hour after to give them. With immunosuppressants, you have 30 minutes before and 30 minutes after. So that's why it's important to get to work early so you can see all of the medications you're giving your patients. And if they are on an immunosuppressant, if it's due at 12 o'clock, you can give it as early as 11:30 and as late as 12:30. So you want to plan your day out to make sure you give it on time. And if something happens and you're not going to give it on time, ask your charge nurse or a fellow nurse to help you and say, please, this medication cannot be late. Can you give this for me? My patient just ripped out their IV and is bleeding everywhere. I need to go help them, right? Read the section on UTI. And this is pretty standard. This won't be difficult for you. Pyelonephritis is a very bad infection that has moved up to the kidneys. And so just read through the symptoms. BPH, benign prostatic hyperplasia, read through that. This tends to happen in older men and they have to go pee a lot. Nocturia and polyuria, and when they go pee, not all of it comes out. So it increases their risk for UTI. And so they usually have to do a surgery. And so this is not cancer, it's a benign growth of the prostate. So please read that section. For medications, so make sure you're reading all of the renal chapter, right? You're responsible for this, but I'm just hitting on the important parts. So on page 215 at the bottom, urinary tract analgesics. So phenazopyridine, which is called pyridium. Make sure you know this is used to treat bladder spasms. So phenazopyridine is for somebody with a UTI, and when they go pee, there's spasms and it hurts a lot. So this medication will remove those, will reduce those spasms. Make sure you know that it causes the urine to turn red or orange. Okay. And so, and then here are the medications used to prevent organ rejection. They're called immunosuppressants. So the three to know are, and so what page is this? Let's look at the page number. So make sure you read on page 217, cyclosporine, sirolimus, and tacrolimus. Okay. Others include azathioprine and mycophenolate. okay, and mercaptopurine. So these medications, if you see these medications on your patient's medication list, they are on an immunosuppressant. So you want to make sure you know why they're on it and when you need to give it. Okay, so make sure you read that section. Meds for preventing organ rejection. You must take them at the same time each day to prevent rejection. And remember, the name says that they are an immunosuppressant. They suppress the immune system. So this is for somebody who has gotten an organ transplant, and we give them these medications so that the patient's own immune system doesn't attack the transplant and reject it. So because we're giving them something that's suppressing their immune system, they are at risk for infection. Okay, so please read those, and then you should be well prepared for renal. Okay, so I'm going to post this recording as soon as it is finished, but please keep in mind you need to review the recordings for renal part 1 and renal part 2. Okay, so in the document I send each week that has the recordings, okay, you will see at the top, let's make this bigger. You will see at the top it has the link to the study guide, and this is the study guide you need to read the section on renal, okay? And it's in module 6. Here's the Zoom link, it never changes. Here's for all the online flashcards, okay? And we're in module 6, so you can see respiratory part 1 and 2, and then renal part 1 is here, and I'm going to post renal part 2, which is what we did today. And so what you need to do is make sure that you have read all of renal in the study guide, that you have watched the recording from part 1 and the recording from today, that you're reading your notes, and that you're doing practice questions on renal. Next, when we come back again for class, we're going to finish module 6 by doing GI. So if you want to get ahead, you can read the section on GI once you're done with renal. But if you're a little bit behind, just focus on finishing renal. Again, read all of renal in the study guide. It's in module 6. Watch renal part 1 and part 2, the recording. We did part 2 today. Do questions on renal. All right. Now, for next week class is going to be a little short as well. And so thank you so much for your patience with my new schedule. I'm just trying to get things adjusted, but I promise you that we're going to meet and we're going to go over what is important for you to learn. Okay, so I will see you next week and we will be doing GI. Thank you so much, and please have a blessed day. And you know that I'm praying that all of you pass the NCLEX. Thank you and God bless you.